Good morning to all. So I will be speaking on role of glucagon-like peptides, glucagon dual receptor agonist in MASLD. So I will be covering this topic under the introduction, historical aspect, basic science studies, NASH and liver disease, dual and triple GLP analog, side effect of GLP analogs, future directions and summary. Coming to introduction, overweight and obesity cause almost 1.3 million deaths globally, and increasing BMI has been associated with increased mortality rate and with a 29% increase in overall mortality. Steatotic liver diseases have become the most common cause of chronic liver disease worldwide. Treating cardiometabolic risk factors and reducing alcohol intake hold promises for future steatotic liver disease management. So management of SLD or MASLD comes under the multidisciplinary approach. It involves the gastroenterologist and hepatologist, nutrition and lifestyle intervention, and endocrinologist with the help of cardiologic for lipid management, weight reduction, and medical intervention, and health and psychology intervention. To historical aspects, so in the mid to late 20th century, intestinal extracts were found to have blood glucose lowering effect, and in 1970 first incretin hormone GIP was discovered. In 1986, Joel Habner and Holst discovered the GLP-1 hormone. 2005, exenatide was first approved by FDA, and in 2024, Lasker D. Becky Medical Research Award was granted for Joel Habner Knudsen for discovering the GLP hormone. So, what is GLP analogs? GLP is a gut-derived incretin hormone that is secreted from L cells of ileal mucosa. It stimulates insulin release, inhibits glucagon secretion, increases insulin sensitivity in skeletal muscles, and decreases hepatic gluconeogenesis. It slows the gastric emptying, thereby reducing the food intake and appetite reduction, which further stops the beta cell apoptosis, thus improving the glycemic control and reducing the body weight in patients with diabetes. So where does it act? GLP act through the G protein coupled receptors, and thereby stimulating the conversion from ATP to cyclic AMP and pyruvate kinase, stimulating the calcium release and causing the insulin secretions. It has also effect on cyclic AMP receptor elements, and thereby further stimulating the insulin release. Other pleiotropic effect of GLP analogs are through the heart releasing of atrial natriuretic peptide ANP secretory granules, which further acts on adipocytes, causing lipolysis, thermogenesis, adiponectin through kidney, causing inner medullary collecting duct cells, increasing the cyclic GMP and sodium excretion, causes sodium release, and it stimulates the vascular smooth muscles, and by the cyclic GMP actions causing vasorelaxation, and by endothelial cells it increases the permeability. So it has pleiotropic effects of GLP analog in MASLD. In brain, it increases the satiety, thereby reducing the appetite, decreasing food intake, increasing the weight loss. In heart, it increases the glucose utilization, cardioprotective effect. In adipose tissue, it decreases the lipolysis, free fatty acid reflux, inflammatory biomarkers, and increases the adiponectin. In stomach, it decreases the gastric emptying, and pancreas, it stimulates the insulin release, decreases glucagon, and improves the beta cell functions. In kidney, it increases the diuresis and natriuresis, thereby decreasing the blood pressure. In muscles, it increases the muscle insulin sensitivity, and which leads to further increase in glucose uptake, thereby causing increased hepatic insulin sensitivity, decreased gluconeogenesis, decreased glycogenolysis, de novo lipogenesis, and decreased triglyceride secretion, causing decrease in hepatic inflammation, steatosis, and MASLD or MASH resolution. So in brain, it acts through the area prostrema and nuclear tractus solitarius, thereby reducing the appetite, increasing the satiety. So decreasing the appetite, increasing satiety, decreasing calorie intake, and body weight through the nuclear tractus solitarius and area postrema. So GLP analog has established benefit in kidney diseases, myocardial infarction, heart failure with preserved ejection fraction, decreases stroke. It has gained evidence in diabetes, decreasing HbA1c, cardiorenal disorders, decreasing the major cardiovascular events, heart failure, diabetic kidney diseases, cardiovascular deaths, and obesity. But in the metabolic liver disease, it is still under investigation and not approved by the FDA GLP analogs. So coming to basic science studies, how the GLP analogs improves the hepatic inflammation and fibrosis. So in this mouse model of sclerosing cholangitis, displaying the hepatic inflammation and fibrosis, it shows that tedugliptide GLP, it stimulates the FGF factors and inactivates the hepatic steatotic cells, thereby causing the hepatic stellate cells less active and decreases the fibrogenesis and inflammation. In another model of NASH, GLP analog was coupled with the GLP-1, GLP-2 and the fusion proteins, and they showed that coupled GLP-1 and GLP-2, it decreases the inflammation in the form of NF-kappa beta, IL-1 beta, IL-6 and TNF-alpha. So it causes metabolic improvements in form of reducing body weight, hepatic triglycerides, serum glucose levels. It improves the liver health by decreasing fibrosis, gut-liver axis increasing by enhancing the intestinal barrier integrity, and improves the microbiome modulations. Another mice study which takes into account the dual glucagon like peptide and GLP receptor agonist in NASH and hepatic regeneration, and it showed that this G49 dual glucagon receptors and agonist, it improved the NASH features in the form of reducing inflammation, steatosis, oxidative stress, apoptosis, enhance the liver regeneration, metabolic benefits, and potential in obesity, decreases the obesity. Coming to human studies, the LEAN trial 2016 was one of the first studies to study the liraglutide safety and efficacy in patients with non-alcoholic steatohepatitis. It was a multi-center, double-blind, randomized, placebo-controlled trial, in which the patient received liraglutide 1.8 milligram compared with the placebo, and it showed that 39% of patients who received liraglutide had resolution of definite NASH as compared to 9% in the placebo arm. Also, 9% in the liraglutide versus 36% in the placebo had a progression of fibrosis. But it comes with the side effect. 81% had developed the adverse events. This graph further shows the patient who has responded to liraglutide has reduced the weight as compared to the patient who were non-responder to liraglutide. Simultaneously, HbA1c reduction was also seen in patient who had responded with the liraglutide. Coming to next study, once weekly semaglutide in adults with NASH patients and overweight and obese patients. It included 1961 patients with BMI of more than 30, and they randomized to 2:1 ratio with a dose of semaglutide of 2.4 mg versus placebo, and primary endpoint was a change in body weight and weight reduction of at least 5%. They showed that patient who received semaglutide 2.4 milligram has better body weight change from the baseline, and it showed that 86% the patient who received semaglutide has a decrease in weight reduction of more than 5% versus 31% in the placebo arm. The change in body weight from baseline to 68 weeks was -15.3 kg in the semaglutide as compared to the placebo. So also coming to adverse event, it has almost 90% of any adverse event, though serious adverse event was noted in only 10% as compared to the 6.4% placebo, and 7% required the discontinuation of therapy. So semaglutide response was also assessed with the artificial intelligence, and in this study of 2023, they compared the machine learning with the pathologist evaluation, and they showed that machine learning assessment detected significant fibrosis reduction with semaglutide 0.4 mg versus placebo. Both methods showed comparable with the NASH resolution, and they showed that 0.4 mg of semaglutide, this was pathologist and this was machine learning. So 0.4 mg was comparable in the both of these graphs, and they showed that machine learning categorical assessment reproduced pathologist results of histological improvement with semaglutide for steatosis and disease activity. Also, machine learning based continuous scores demonstrated an anti-fibrotic effect which was not seen by the histopathologist. So machine learning can be a assessment or response which can help pathologist. Coming to next study, the effect of novel, that is dual GIP and GLP receptor agonist tirzepatide on the biomarkers of NASH with diabetes. The patient with diabetes either received once weekly tirzepatide 1, 5, 10, 15 milligram or dulaglutide and versus placebo, and they have seen the changes from baseline in the in biomarkers including ALT, AST, creatine, procollagen, and adiponectin, and they showed that biomarker improvement with the tirzepatide was significant with reduction in ALT, AST, keratin 18, procollagen. It increases the adiponectin level and causes weight loss. This graph also shows that a patient who has the dark line with the dark blue line, that tirzepatide 15 milligram has a more reduction in ALT, AST, procollagen, adiponectin, and keratin. So study for the children. This was the first study, and there is no other study in the children also. So liraglutide for children 6 to 12 years of age with obesity. In this phase 3 trial, 56 period of treatment follow-up, they randomized the patient of 6 to 12 years of age with obesity into 2:1 ratio, liraglutide with placebo, and they with a BMI more than 30 in the both arms. The primary endpoint was the percentage change in the body BMI, and secondary endpoint was a percentage change in body weight and BMI at least 5%. They showed that patient BMI reduction was more significant with the liraglutide in children, and also the percentage change was significant with the liraglutide arm. And if you see the lower graph, that showed that 46% achieved more than 5% reduction, 35% achieved more than 10% reduction in body weight, and 15% achieve more than 15, and almost 8% achieve more than 20% reduction in the body weight from the baseline. It comes with an adverse effect, so almost 89% has developed adverse effect of any, and 80% has developed GI adverse effect. Mostly they were nausea, vomiting, and diarrhea. So does liraglutide alleviate inflammation in brain donors also, brain dead donors? So this was a 24-hour study in which they gave 3 mg of liraglutide, that is 0.5 ml, 6 hours apart to the probable brain dead donors. And they showed that liraglutide treatment of brain dead donors reduces the IL-6 and prevents the increase of IL-10 levels compared to placebo. And this hypothesis generating study suggests that alleviating inflammation may reduce brain dead donor induced organ damage and help in retrieving the organ. So coming to oral or for glipron, that is GLP and analog, and it was a phase 2 randomized double-blind study involving patient with obesity, diabetes, and SLD. Orforglipron is a once daily oral non-peptide partial agonist of GLP-1 receptor, and it has a greater effect of cyclic AMP, and also because of the slow degradation, it has a longer effect. And it showed that the percentage change in the body weight with the orforglipron with the 12 mg was minus 8.6, 24 mg minus 11.2, 36 mg 12.3, and 12.6 versus placebo. So the oral, although it is not available in India, but it has a more reduction in the weight as the dose was increased. But it has side effects also, 86%, 87, 83, 97%, the maximum side effect with the 97, 90 with the high doses. So but the serious side effects were very less, and all were almost GI related side effects. Coming to tirzepatide for the MASH fibrosis, it was a phase 2 dose finding multi-center double-blind randomized study, and tirzepatide was given once weekly. It is a dual GIP and GLP-1 receptor agonist. The primary endpoint was the resolution of MASH without worsening of fibrosis at 52 weeks. And they included the patient who has a BMI of 36 comparable in all the 4 arms of increasing dose and placebo, and NAFLD activity score was 5.4 comparable in all arms, and they showed the resolution of MASH with no worsening of fibrosis was achieved with the tirzepatide 15 milligram, and it was significant as compared to placebo in all 3 of 5 mg, 10 mg, and 15 mg. Also, decrease in fibrosis of more than 1 grade and no worsening of MASH was seen with the tirzepatide 5, 10, 15 milligram as compared to the placebo arm. So it also has a side effect of around 91%, and mostly they were GI related side effects. So survodutide in MASH and fibrosis. Survodutide is also a dual agonist of glucagon receptor and GLP-1 receptors that is derived from the glucagon, and it was also administered once weekly. It was a phase 2 trial, and they divided the patient into 1:1:1:1 in 2.4, 4.86 and placebo, and the endpoint was the improvement in histological finding on biopsy after 48 weeks of treatment. They had a comparable BMI of 35 in each arm, and diabetes was present, and they showed that survodutide 2.4, 4.86 mg was they have achieved primary endpoint like resolution of the NASH as compared to the placebo, and it was significant with the 4.8 milligram of 4.8 milligram of survodutide dose. Also, the change in liver enzymes was significant with the every dose as compared to the placebo, and more effect was seen with the high doses. Side effect was seen in almost 97% patients, and though discontinuation required in only 40% cases. This is a new and only drug, retatrutide. It is a triple hormone that act on glucagon receptors, GIP and GLP analog. So it was a phase 2 double-blind randomized placebo-controlled trial, and they distributed with the retatrutide for 1 mg, 2, 4, 8 and 12 mg versus placebo for 48 weeks, and they had the BMI of around 37 in each arm, and body weight of more than 100 in each arm, and they showed that reduction in the percent body weight with the retatrutide was significant as compared to the placebo, and almost minus 23.9, almost 23 kg of weight minus was achieved with the retatrutide and from the baseline. So they concluded that the mean percentage change in body weight at 24 weeks in the retatrutide group was minus 7.2% in 1 mg, and it increased to 17.5 mg in the 12 mg group as compared to 1.6% in the placebo group. So coming to pemvidutide, a GLP-1 and dual receptor agonist, they also included BMI of more than 28 and liver fat content of more than 10% by MRI, and they studied these patients who have BMI of around 36 at more than 35, and they showed that liver fat content was reduced with the pemvidutide, and there was more than 30%, 50% and normalization of the liver fat content was seen with the pemvidutide dose of 1.8, 2.4 as compared to the placebo. With the placebo it was almost minimal. So how does it act? It acts through the glucagon also. It is a dual receptor, and also acts through the GLP analog, which acts through the release of the GLP analog from the ileal mucosa, and also pleiotropic effect through the brain, decreasing the appetite, inflammation and decreasing the gastric emptying. The side effect with the pemvidutide was minimal, and they showed only 16% has developed GI related side effects, and in the form of diarrhea. So if I summarize the MASH resolution studies and major studies, and then you can show that these right sided they favor the GLP analog in the MASH resolution, and the studies were Armstrong, Newsom, Lombard et al. 2023, and dual receptor Lombard and Sanyal. They all showed that the odd ratio was significant in MASH resolution, and it favors the GLP analog. Liver fibrosis reversal was also significant with the Armstrong study, Newsom study, and Lombard and Sanyal study, with the odd ratio of 2.3, 1.5, 2.6 and 1.3, which also favors fibrosis reversal. GLP analog favors the fibrosis reversal. So other pleiotropic effect of GLP analog are seen in the form of sarcopenia, and dulaglutide, liraglutide and exenatide. They increase the muscle protein synthesis and muscle microvascular blood flow, and decreases the muscle protein breakdown in patients with diabetes, and they also all the studies have shown that there is an increase in muscle mass. Liraglutide and obesity in elderly, that efficacy in fat loss and safety in order to prevent sarcopenia. This was a prospective case series study, and they included patients with diabetes and HbA1c of more than 7, and they assessed with the skeletal muscle index and DEXA, and they showed that reduction in fat mass and android fat with the preservation of muscle tropism in order to prevent sarcopenia more with the liraglutide. Also, tirzepatide reduces the appetite, energy intake, and also reduces the fat mass and decreasing the obesity sarcopenia with type 2 diabetes patients. So in coming to metabolic kidney diseases, the patients that is dulaglutide, liraglutide, and they all have shown that there is a decrease in the incidence of macroalbuminuria, decreased incidence of new macroalbuminuria, sustained rather it increases the GFR, I will show in the further studies, and decreases the proteinuria. And this study showed that dulaglutide versus insulin. They compared in the AWARD 7 study, they compared the dulaglutide versus the insulin, and they showed that glycemic control was similar to insulin glargine with reduced decline in eGFR in the GLP analog as compared to the insulin. And this study on semaglutide on CKD in patients with diabetes, they randomized the patients with diabetes and CKD to receive the subcutaneous semaglutide at a dose of 1 mg weekly versus placebo, and primary outcome was the major kidney adverse event and 50% reduction in the eGFR from the baseline, and they showed that the first major kidney disease event was less in patient with semaglutide as compared to the placebo. Also, the decline in GFR was noted less noted with the semaglutide as compared to the placebo. So coming to cardiovascular disease that has pleiotropic effects, decreases the new onset of MI, stroke, death due to cardiovascular event, and because of the decreased atherogenesis and increased blood flow to the vascular system. So there is a meta-analysis of trials testing multiple GLP receptor agonists in diabetic patients and revealed that major adverse cardiovascular event in the form of stroke, MI, cardiovascular death decreased by 12% in treated patients irrespective of drug used in the population studies, and also there was 9% reduction in hospitalization due to heart failure. Also, it has favorable benefits in neurodegenerative diseases and neurodegenerative diseases, and also the aging. GLP analog causes inactivation of telomerase, which is a key contributor to cell aging and leading to senescence. So liraglutide mediated increase in telomerase activity and its translocation to the nucleus, so it helps in aging also. And it has a pleiotropic effect in the form of decreasing the incidence of cancer, but few studies have showed that liraglutide and semaglutide has been shown to increase the risk of thyroid and pancreas cancer, although there were meta-analysis which I will show that there was no significant increase. It has an effect on the alcohol liver disease also. So what does it causes? It acts on the nutrictus solitarius and area postrema, as I told earlier, and it reduces the activity in areas for the addiction and drug reward through the ventral striatum and septal area. So reduces dopamine transporter activities, and dopamine remains longer in the synapses, and so it causes reduced alcohol intake, reduced food intake, and reduced substance abuse. So there is no studies, but it is a postulation, so further studies can be done. GLP analogs come with the side effect. It decreases the weight, HbA1c, heart failure, MI, stroke, but it causes the side effect in the form of nausea, vomiting, constipation, mainly GI, and also gallbladder diseases and pancreatic. So red one showed the more side effect: nausea, vomiting, constipation, diarrhea, decreases the bowel motility, ileus, risk of ileus can be there, reduced gastric emptying, gallbladder disease can be there with the form of cancer also, or cholestasis can also be seen. Thyroid cancer and pancreatic cancer are the possible side effect because of the GLP analogs. So in this study there is a large cohort of all the GLP analog, and they showed that use of GLP agonist for weight loss compared with the bupropion, they showed that increased risk of pancreatitis, gastroparesis, bowel obstruction. These all are due to decreasing the decreased mortality caused by the GLP analogs. So it decreases the gastric emptying, causes GI side effect. So caution should be used in the patients who have gallbladder diseases. There is a risk of hypoglycemia also, and the reason for causing the gallbladder disease is attenuates the cholecystokinase stimulated gallbladder emptying, which was the reason. Pancreatitis and thyroid cancer, they had only one study was there which has showed that there is a increased risk of pancreatic and thyroid cancer, but after that multiple studies and meta-analysis have showed that it does not, there is a minimal risk with pancreatitis and pancreatic cancer. And in the multiple studies I showed the adverse event were only the GI side effect, and the pancreatitis or pancreatic cancers were minimal. Though niraglutide, as I told earlier, in the leader randomized trial, they showed there is a 10% increase in the risk of developing de novo malignancy. It was more of the colon cancer and gallbladder cancer and pancreatic cancer in this study. So with this, all the side effects and the improvement, ASLD practice guidelines 2023, they cautiously says that semaglutide can be considered for its approved indication in patient with NASH, as it confers a cardiovascular benefit and improved NASH. Apart from this, ASLD does not speak of any other GLP analog, as few more of the studies has gone in 2024, so further studies may be there. Coming to liver disease, the GLP analog and liver disease. So GLP analog, this study, they have compared the GLP analog with the DPP-4 inhibitors, with the sulfonylurea and the SGLT2 inhibitors in the large cohort of around 6,000, 10,000 and 3,000 patients. And they showed that GLP analog versus DPP-4 inhibitor, the risk was less in the patients with the GLP analog. Cumulative incidence of adverse event was less in patients of GLP analog, as similarly with the sulfonylurea and SGLT2 inhibitors. So GLP analog were compared and they found that it was comparable. Number of events, if you see with the DPP-4 inhibitor 69 in the compensated cirrhosis, as compared to sulfonylurea 86 versus 53 and 44 versus 38. They also taken decompensated cirrhosis. This was the only study which took the decompensated cirrhosis, and they also showed that the main decompensation in these patients was only bleed, and they showed that the number of events in decompensated cirrhosis also was less in GLP analog as compared to DPP-4, sulfonylurea and SGLT2 was comparable. Another study which showed that GLP receptor agonist and risk of major adverse liver outcome MALO in patients with chronic liver disease and type 2 diabetes. They showed that 10-year risk of major adverse liver outcomes was 13.3 and versus 14.6% in non-initiated in intention to treat trial, and 10-year per protocol risk estimates was 7.4% versus 14.4% in GLP analog, reducing the risk of major adverse liver outcomes. The number of events, as you can see, these were the events with the GLP analog, and they were less as compared to the other non-initiators. There are marked changes: 21 versus 303, 21 versus 688. Number of event GLP analog in the initiator among non-initiators. So in MASLD there was only 21 events as compared to 303 in the other than MASLD, also 21 688, and cirrhosis status as baseline in patient with compensated cirrhosis was also 23 events only as compared to 286 and 19 in patients with no cirrhosis 546. So this graph further showed that event probability with the GLP agonist initiator was less in patients with as compared to the patient who did not initiated the GLP analog. So this European cohort study, association of GLP analog receptor agonist with serious liver events among patients with type 2 diabetes. They studied the impact of GLP analog on hard hepatic endpoints, and they showed that GLP receptor agonist and the risk of serious liver events in routine they studied, and they showed that the GLP analog had a cumulative less incidence of the hard serious liver event, and they even subgrouped it, and you can see that the event per 10,000 population was 608 in patient with GLP as compared to the DPP-4, which was 1770 with the hazard ratio of 0.84, and it was less than 1, as you can see the adjusted hazard ratio also. They have subgroup with the age and the sex also, and it was maintained that the events were less in patient with who received GLP analog as compared to none. So this is the same. So another study in the CGH which showed that GLP receptor agonist in patients with liver cirrhosis and type 2 diabetes. They investigated the long-term outcome of GLP receptor agonist in patients with diabetes, and 467 matched pairs of GLP receptors were compared. It is a Taiwan study, and they showed the was 3 years, and they showed that death outcomes was less in patients with who received GLP analog, and also it was seen in the major adverse cardiovascular event, decompensated cirrhosis events, varicose bleeding, ascites, hepatic encephalopathy, jaundice. So and acute and chronic liver failure incidence of HCC almost was same. So they showed that these death and the cardiovascular event, decompensated cirrhosis, and the risk of decompensation was less in patients who received GLP analog as compared to the patient who did not receive. Also, the death was less, and the major advanced clinical cardiovascular outcomes were less. So they propose that what is the mechanism in cirrhosis? They propose that these GLP analog decreases the hepatic steatosis and hepatocyte injury, reducing the insulin sensitivity and lipotoxicity, and decreases the ER stress. They modulate the gut microbiota, reduces the intestinal inflammation. They induce signaling pathways by promoting the neurogenesis and decreases the inflammation, and they improve the imbalance of neurotransmitters. So after studying all the glorifying benefit of GLP agonist, no GLP analog has been approved by the FDA till now, because they said that there is a fibrosis reversal is not long standing, and the effects are due to weight loss, glycemic control, lower glucose, lower alcohol intake, which can be corroborated with the bariatric surgery, balloon placement of all the lifestyle modification. They all can be done with the same. So they said that they have not no FDA approval has been seen, and so they said that maybe long-term follow-up is needed to see for the reversal of fibrosis. So let's go for the real-world adherence, whether the GLP analog patient were able to take. So this is the study. The patient were required to be continuously enrolled for 12 months for their GLP receptor prescription, and 4,791 diabetes patients with more than one or more than two prescription of GLP analog were enrolled. Over half of diabetes patients initiating GLP receptor agonist was non-adherent. So 70% almost were non-adherent to the GLP analog at 24 months. So this you can see clearly that 70% were non-adherent and also in 1 year follow-up 47% were non-adherent. So this is very important, but that although GLP analog are very glorifying in reducing the MASH fibrosis, but it comes with a side effect, and patients are not able to take, almost 50% patients are not able to take these GLP analog in 1 year. So another important study in the Lancet, and they showed that whether the weight loss which has been done by the GLP analog is sustained or not. So they investigated whether weight loss and improved body composition are sustained better at 1 year after treatment, after termination of active treatment with GLP analog, and 109 patients were enrolled. And if you see that this patient this graph, and they showed that patient who were taking only GLP analog in the form of liraglutide, they regained the weight as compared to the patient who were taking liraglutide with exercise, only exercise or placebo. So non-adherence and the weight regain was more with the GLP analog in the form of liraglutide. So this is another important slide that showed the patient who were taking liraglutide, they had the minimum physical activities, and so this was assessed with the moderate to vigorous physical activity, and they showed that the patient who were taking liraglutide has most sedentary lifestyle as compared to the patient who were exercising, and or compared with the exercise who were having exercise with the liraglutide. So the sedentary lifestyle was seen more with the patient who were taking GLP analog only as compared to the exercise and liraglutide. So to summarize, much of the clinical trial data is limited to patients with diabetes, obesity, and both. Hence, targeting metabolic abnormalities associated with these conditions is the main mechanism of action of GLP analog. And MASH cirrhosis, there are a few studies which have taken into account the MASH cirrhosis. So the action of these GLP analog, in summarizing, is decrease in obesity, decrease alcohol craving, decreases hyperglycemia, and hepatic steatosis, inflammation, and fibrogenesis. So a way forward is to need long-term follow-up in NASH MASLD patient with or without diabetes and obesity. Using cirrhosis patients should be considered, and study should be planned. Careful selection of patient is important. Side effect monitoring, almost 80 to 90% patient had developed side effect with these GLP analog, and personalized approach is important. Cost is very important. Semaglutide is available and it costs around 3,000 one strip, so 3 mg, and 7 mg doubles the cost, so it comes with the challenges. So thank you.